Hey everyone, it's Mike Mutzel with High Intensity Health Radio, where we cover the best of fitness, nutrition, and functional medicine. So glad that you joined us, because today we're going to talk about heart disease from a totally new perspective, really from the angle of physiomechanics and blood viscosity and the stickiness of blood. That's something that a lot of individuals in preventative or integrative medicine are not really talking about. And also in the traditional realm, those individuals are not talking about that either. So we dive into that with my good friend and integrative medicine expert, Dr. Ralph Holsworth. And he knows this firsthand. He's actually an emergency room physician. That's what he does on his day job, so to speak. And at night and on weekends, he's an avid researcher. He's well published. He's done a lot of research in the field of enzymes, proteolytic enzymes, and we talk about serrapeptase and nattokinase, and we also talk about blood viscosity. That's kind of his new big interest level right now. He actually worked with Jonathan Wright to develop a blood viscosity test that you'll learn more about. Why am I making such a big deal about blood viscosity? Well, it's actually linked with an 88% reduction in heart disease risk if you can lower your blood viscosity. So we talk about all these different studies. He's looked at 300 some odd studies, and out of all the different risk factors, blood viscosity keeps coming up as even more predictive or more indicative of high cardiovascular risk compared to smoking. And we know smoking is one of these really problematic risk factors. So you're going to learn a lot about this and therapeutic applications that you can implement in your life. The use of enzymes, donating blood, exercise, proper sleep, and burning that belly fat to reduce plasminogen activator inhibitor 1, or PI1, that we talk about. And I know it's a mouthful, but you're going to learn more about that. So I really hope you enjoy, and if you do, please subscribe to the YouTube channel. And you can also listen to this over in iTunes or on Stitcher. High Intensity Health Radio, just type that in and you'll pull it up, and you can subscribe there too. Hope you enjoy and have a great one.
Between diastole and systole, or the relaxed and squeezing stages of the heart, blood thickens 4 to 6 fold. If you can imagine the blood sort of starting and stopping and starting and stopping, and this sets up the flow dynamics, and it's really the hemorrheology, or the physics of the blood, that contributes to atherogenesis. So once blood becomes thick, it actually causes a sterile inflammation on the endothelium, and you get what we call endothelial dysfunction, which you mentioned very eloquently again in your book.
Welcome to High Intensity Health Radio, the best of fitness, nutrition, and functional medicine.
And now here's your host, Mike Mutzel.
All right, welcome back, everyone. I'm very excited for today's guest. We have with us Dr. Ralph Holsworth. He's a proteolytic enzyme expert and also an expert in blood viscosity, which is going to be the topic today. So get ready for that. So Dr. Holsworth is a doctor of osteopathic medicine, and he's board certified in family medicine as well. He has served as the environmental scientific consultant for the EPA, the Environmental Protection Agency, an honorary professor at the University of Colorado Department of Biology, and multiple other publications and so forth that Dr. Ralph will get into. But Dr. Ralph, welcome.
Thank you. I really appreciate this opportunity, Mike.
Yeah, I'm very excited to chat with you. We've known each other, I think, since 2007, and we've both lived in Colorado, and then you were in Seattle, and then now you're back in Colorado. So let's talk about your background, your work with enzymes, and then how you've transitioned to be an expert in blood viscosity. And
you bet. I went to medical school, and during medical school, I had a friend of mine give me a book, and it's called Enzymes, the Fountain of Life. Well, David Williams was one of the authors, and so, one of my bad habits is when I read a book or something that excites me, which that book did profoundly, I will call up the author and try to get more information. And so that led into an academic relationship with Dr. Williams, who is a MD, PhD. He was an oncologist, one of the top doctors involved with Cancer Treatment Centers of America. And then, lo and behold, he introduced me to Dr. Karl Ronberger, PhD. And of course, you've heard of Mucos Pharmaceutical, the German company, which actually the Wombenzyme. So that's really how I got into enzymes, reading a book and digging a little bit deeper and trying to meet the people in the know. And I credit Dr. Karl Ronberger for giving me a tremendous amount of direction in looking at the clinical applications and therapeutic attributes of it. And probably about 3 or 4 months prior to his death, he had mentioned nattokinase, and he'd actually, which was it was sort of out of character as a German researcher. He was very keen on sticking on task and just, did tremendous amounts of research with enzyme. So for him to bring nattokinase up, I thought, well, there's something there. So I credit him also for allowing me to go over to Japan and meet Dr. Hiyoki Sumi. I've met with him twice, and that continued my pathway, especially after his departure.
Fascinating. Yeah, I knew that we would get along and be good friends when we first spoke on the phone. And this was, I think, a Friday afternoon, and you were doing hospital work at the time. And then you said, yeah, well, my weekends are really devoted to studying and research. And at the time, that's all I was doing as well. So, so you're also working in the hospital setting. What exactly are you doing there?
Well, I work in a very small rural setting, and I cover the emergency room 24/7 for about 12 days. And that allows me to just stay up to date with a lot of therapeutics, and allows me to basically get the, research from, we always say from the bench top to the bedside. And so that's, I think, really integral that I'm grounded there. I see the inadequacies and sometimes just where we can, do a better job. And so that's what I get to do, and I really enjoy it in a very small rural community in Colorado.
That's great. Now, do you get to use any of these enzymes that you studied clinically at the hospital, or is that more in your outpatient if you do see patients on the side? How does that work?
Well, I don't use them in the emergency room per se, but I do have quite a few clinical patients. So I actually do three things, and it sounds a little, it's not multitask, but I do cover the ER. I do have clinic patients, and I also admit people to the hospital. So during that time, yes, absolutely, I've been able to use enzymes and then some integrative therapy, IV, glutathione, phosphatidylcholine, the butyrates, a number of integrated vitamins, ascorbic acid. So, yeah, they're very, I'll call tolerant of my... But it's all supportive, and I just have more tools in my tool bag, and so my patients really appreciate that, and that's who I'm always striving to meet their expectations and help them along their health journey.
Yeah, that's fascinating. So let's dive into proteolytic enzymes, and what are they and how do they work? A lot of people think that if you take an enzyme, it's going to be broken down by hydrochloric acid in the GI tract, but we know that not to be true. So let's walk us through the science here and talk about some of the most potent ones that people can take.
Oh, absolutely. So there's a number of different broad categories. They actually have different numbers. It's sort of like a zip code, and each number tells exactly what it cleaves or what it breaks off from a protein. So for the most part, all the therapeutic enzymes that we use are from a large classification called class 3, which are called hydrolase. And what that means, first I should preface, anything that ends in ASE suffix usually biochemically suggests that it is an enzyme. There are always exceptions, but the modern nomenclature dictates that. So we have hydrolase, and what that means simply is that they're going to break a protein open and put a water molecule. So I tell everyone, think of proteolytic enzymes as having a water axe. They're going to break the protein down by putting in a water molecule. And of course, different enzymes do that in different manners and ways. So there's, we break those down into further classifications from that. So, but the majority of them are what we call endopeptidase, meaning they cleave inside bonds, not exo, in other words, the ones on the outside of a long protein chain.
Okay, so they basically cleave the water, and that's how they are able to break up larger molecules into smaller their component parts.
Well, yeah, they cleave the proteins, but they do it by putting in a water molecule. And I should say that is a biochemical catalyst. In other words, that there are chemical reactions in the body, as you know, with your background, that would never, ever happen unless there was an enzyme, taking the, product A to product B substrate.
That's great. There's trypsin, chymotrypsin, there's serrapeptidase, and then nattokinase I would like to talk about at the end because that'll give us a nice segue into blood viscosity. But let's talk about some of the new enzymes that are out there and maybe potentially better than that. So anything on just the basics, trypsin, chymotrypsinogen, and then also serrapeptidase that you want to speak to?
Oh, absolutely. And you mentioned earlier, which I thought was very adroit, was that, the common perception is that these enzymes are broken down by hydrochloric acid. Well, there are some that have sensitivities to stomach pHs, but in the large part, these enzymes are shuttled into the immune system through the GALT, which is gut-associated lymphoid tissue, and they bind immediately to the immune system. So very similar to a infant breastfeeding, it's getting its IgA secretion, it's getting that from the breast milk. So again, very similar that we do know, and it's been very well documented that we do have endogenous activity from enzymes that we ingest in our system. So, and they go right into the immune system. So in contrast with pharmaceutical drugs, which, as you know, portal vein, go through the P450 liver, phase 1, phase 2 breakdown, and then it's really the byproducts or metabolites that cause the effects of pharmaceutical drugs. Enzymes pretty much go right into the immune system, and I think that's why we see generally, I personally have not witnessed any adverse drug reactions, if you will, to enzymes because of that ability to identify, if you will, with the immune system.
Wow. So we're bypassing the whole liver, detoxification pathways and is it, Dr. Holsworth, going through the lymphatic vessels and right into the immune system that way?
Exactly. The macrophages, and there's a particular, I call it the enzyme bus, if you will. Those are called alpha-2 macroglobulins, antitryptase. So there's various different ones, but for the most part, alpha-2 macroglobulin is basically a venous flytrap mechanism. It's a very large protein. It actually has a little bait, a little trigger. Your protease enzymes will actually trigger that, and then you'll see that activates it. It clamps down on it like the venous, i.e. the fly being the enzyme and the venous flytrap being this alpha-2 macroglobulin. And then that shuttles it to wherever it needs to be in the body. And you'll hear some lay people mention the intelligence of enzymes. And I think academically I'm okay with that because there is an intelligence, because it is basically going right into the immune system and assisting whatever the immune system's major task is. So I tell a lot of people, if you want to go to a fire, chances are if you jump on a fire truck with bells and sirens going, you're going to end up in a fire. Same thing, enzymes, they couple onto this alpha-2 macroglobulin, i.e. the fire truck. They're going to go to the nidus of inflammatory, wherever that is in the body.
And when they get there, we're talking about adding water molecules to break up proteins. What exactly are these proteins? Are these inflammatory proteins created by the immune system? I mean, how does it reduce inflammation or improve mobility or any of the other benefits?
That's an excellent question, and it's a little bit complex, but the short story is that it revs up the immune. So technically, enzymes are called biological response modulators. So that's a certain category that it neither is a specific immune stimulator nor suppressant. It just does the right thing when it needs to be. So absolutely, the other thing, when you bind this to the alpha-2 macroglobulin, it goes from a slow stage to a fast stage. So what that means is it's taking the garbage out. Instead of doing it once a week, it's doing it once every hour or every two. I mean, my analogy is, that's a general analogy, but what that's doing is taking out these immune complexes, this crosstalk that we see in autoimmune diseases and cancer, in cardiac diseases. So you're absolutely correct. It has a significant direct and indirect, effect on the immune system. But overall, it's very therapeutic for the body.
Sure. And what about post-injury? People roll their ankle, sprain their wrist, something like that, where there's a lot of localized inflammation. What do you generally recommend in terms of dosing? Empty stomach, full stomach, how many times a day? What would be your general protocol there?
Well, my general protocol as an ER doc, I'm getting away from NSAIDs completely. I've taken some training in prolo therapy, and that's really even focused my attention that I can't delay the inflammatory process. It's been with us for thousands and thousands of years. It's really why we're here today. It's a success story as far as, as humans are concerned, any mammal. But the short story is that when you take enzymes, that's going to push you through the inflammatory and actually cut your healing time, if you will, about 50%. That was well documented in at least 20, 30 studies that I know of. But to answer your other question, bromelain is what I usually recommend. You can take some of these enzymes. I think a lot of them, with wombenzyme, they had recommended that be on an empty stomach, i.e. 1 hour before or 2 hours after. That's important, but it has more to do specifically with some of the enzymes in that formulation that are not tolerant to the pH. And that's different for different enzymes. So you can't always recommend, taking them on an empty stomach, specifically with nattokinase. I know there's still some confusion amongst some of the health professionals regarding that. So.
Sure. Now, what about serrapeptidase? I know that's one that has a lot of research for maybe biofilm and things of that sort. Any updates from your perspective?
I find it an amazing enzyme, because it's, specifically, it's a mucolytic. I mean, that's what I've used it with chronic sinusitis. I've used it with anybody with COPD, reactive airway diseases, bronchiectasis. Interesting enough, in Japan, they really look at enzymes as being a pharmaceutical drug. And there's actually one enzyme, it's a type of serrapeptidase that they actually have combined with an antibiotic, and its specific use is for sinusitis. It increases the bioavailability. Again, if I can refer back to my previous explanation of how enzymes are picked up by the immune system, the alpha-2 macroglobulin, etc., that makes, a little dab will do it. In other words, it enhances the availability of whatever like that previous antibiotic. It helps penetrate the sinuses, which can be sort of an immune privileged area in a lot of humans, or, like as you mentioned, the biofilms. That's a classic area for biofilms, as well as the biliary tree, so excellent point.
What I've seen available now is the ability to, instead of using enteric coating, which I know enteric coating, there's a lot of heat involved from a manufacturing standpoint, the ability to use acid-resistant vegetable capsules. So you mentioned that the caustic pH of the stomach may be, certain enzymes are intolerant to that. So one way to bypass that is the acid-resistant veggie caps that disperse in the small intestine. Have you looked at that research at all?
It's been some time I've looked at it, but yes, I've a lot of things, specifically with nattokinase, I've looked at a lot of, pharmacokinetics as far as, delivery. And the reason is, I think there should be two types of nattokinase, and I apologize if I'm jumping ahead, but I do know there's a preventative modality for nattokinase, and there's also a therapeutic. In other words, I'll call it a 911 type of use of nattokinase because, as a doctor, I've used it in the emergency room. And that's in settings, very rural settings where I didn't have recombinant TPA or what we call clot busters. So
great. Well, let's segue right into nattokinase and talk more about that. So 2 different forms for 2 different applications. You want to get into those a little in more depth?
Yeah, I think it's just the time of onset. We know once you put nattokinase in your mouth, it's sort of the activity in your bloodstream, in other words, maximum clot busting capacity, if you will, sort of peaks around 6 hours. So someone in atrial fibrillation, someone at a high risk or susceptible for a CVA or stroke, heart attack, blood clot, etc., then I'm recommending they dose QID 4 times a day, particularly at bedtime because, there's a thing called PAI-1, it's PAI-1, which is plasminogen activation inhibitor, when that sort of increases, that's when we see people presenting with their heart attacks and strokes. And you actually reference, I believe, what we call Black Monday. In other words, there's a statistical proportion of males who have acute MI heart attacks on Monday. And again, a lot of that is secondary to max inflammation, sort of the parasympathetics and the PI1 being at its elevated level in the human. So,
wow, that's great. So the nattokinase, is it affecting PI1 or is it just helping with the viscosity? What is it doing exactly?
Oh, that's a great question. It's doing both. And that's why I'm so excited about it, because not only is it's got a little Pac-Man, about 10% of the modus operandi is, eating, chewing up. And it's very specific. Let me back up one second here. It's very specific for cross-linked fibrin. I mean, if it was a Pac-Man, that's all it would eat, would be cross-linked fibrin. So that's very good. It's not in there chewing up your albumin or chewing up any other type of proteins that your body needs. So let me qualify that from the beginning. Secondarily, 10% is actually chewing on the clot, but the majority of the action, just like you said, has to do with that it revs up your PI, your ability, and it revs up your urokinase, it revs up your plasmin. All those are enzymes that your body makes. So there's a synergy, and it upregulates all that. So it's really nurturing nature is the way I'm sure I plagiarized that from someone, but the short story is, it really does put your body in a super defensive mode to break up any clot that may form. And, I've just seen some remarkable cases, as a physician overseeing that and a wide variety of patients.
Great. So I haven't looked at blood viscosity in a long time, but fibrin would be bad. Plasminogen would be good, so to speak?
Exactly.
Okay. So
exactly.
Plasminogen, so the activator inhibitor, PI, it's inhibiting plasminogen activation, so that's why it's bad. So in turn, sleep apnea, belly fat, inflammation, diabetes, and so on are all linked with PI being activated, PI1, which is going to make blood more viscous and increase risk for various cerebrovascular and cardiovascular diseases. Is that where we're going?
That's absolutely correct. And that's really why when I read your book, The Belly Fat Effect, I got so excited because I was like, oh, okay, here's how this comes home. This really, for me at least academically, sort of, pulled it all together for me. Like you said, these are things general protocols and practices we know to be generally accepted as a good thing. But now what you presented, and I was impressed with how many references you had with that book, was, here it is. Here's the science. Here's the research. So, that's where I have to hang.
Awesome. Well, thanks so much. Yeah, it took a while. It took many weekends. And yeah, I'm glad that you found it helpful, and hopefully other people will find it helpful as well. So yeah, we know, Dr. Holsworth, cardiovascular disease continues to be the number one killer worldwide. And we've been talking about thick blood and so forth. Let's define blood viscosity and what that is and why that's so problematic for our vessels and arterial system.
Absolutely. Another book I read and another author, and I have to give him credit, was Dr. Ken Kinsey, cardiologist. He did a lot of research with Dr. Young Cho. I continue to research with Dr. Young Cho. In medical school, I was like, seemed to be just a litany of different things that created cardiovascular disease. Well, and the common denominator that pulled this all together was, blood viscosity. There's 300 independent cardiac risk factors. If you look at the common denominator in each and every time, it is whole blood viscosity. So it's actually more sensitive than whether a patient smokes or doesn't smoke. And I'll be glad to share all those references and research. So the other thing that gave me, not to digress too much, was, I ran nuclear reactors in the Navy. So I learned a little bit about fluid mechanics. And so once I met with Dr. Kinsey, a cardiologist, and then Dr. Young Cho, a physicist, both leading experts in blood viscosity, then I was able to really apply a lot of the retrofit, if you will, some of my previous knowledge from the Navy and apply that, basically, running a nuclear reactor and preventing corrosion, and apply that to the human circulatory system. And there's differences. Number one, blood is a non-Newtonian fluid, meaning that when you put shear into it, it changes. So probably the one at a lot of people's kitchen table is ketchup. And ketchup, you turn the bottle upside down, it doesn't flow very well, but give it a little jerk and it starts to flow. Well, that's very similar to the flowing. That's a non-Newtonian fluid. Once you impart shear or energy into it, then it starts to flow. So between diastole and systole, or the relaxed and squeezing stages of the heart, blood thickens 4 to 6-fold. If you can imagine the blood sort of starting and stopping and starting and stopping, and this sets up the flow dynamics, and it's really the hemorrheology, or the physics of the blood, that contributes to atherogenesis. And that's not to say I don't completely agree with everything that Faust and the vulnerable plaque and the traditional biochemical models say of how plaque begins. I'm just backing the starting line, if you will, into the bloodstream. So once blood becomes thick, it actually causes a sterile inflammation on the endothelium, and then you get what we call endothelial dysfunction, which you mentioned very eloquently again in your book. So, it all ties in again. So I'm also looking at the physics. And what's very exciting, to bring this home, what's exciting about nattokinase is that my clinical research showed that it decreased blood viscosity anywhere up to 18 to 20%. So huge benefit as far as not thinning the blood technically, but allowing it to flow. But the body's able to clot just as efficiently when it's on nattokinase. It's just that the physical thickness of it is, 18, 20% decreased.
This is really interesting, Ralph, and so you bring up a huge, a curveball on the whole lipid hypothesis of cardiovascular disease, because like you said, we've been focused so much on the biochemical, the cholesterol, the triglycerides, the lipids, even hypertension, but now we dig deeper and can, quantify this, and I'd love for you to talk more about this blood viscosity. So basically, during contraction, we have the shear biomechanics change the whole hemodynamics, and that creates just a localized inflammation in the vascular system. Is that what I'm hearing?
Absolutely, and it occurs in very particular areas. And it's a little bit more complicated because, remember, I said blood has different viscosities. So when it's getting ejected out of the left ventricle into the ascending aorta, etc., then that's what we call high shear. So it's moving very quickly. It has a lot of energy. So that's when we see a lot of arterial sclerosis. In other words, the stretching of the vessels. I guess the easiest way to say this is that when that has a lot to do with the thinness of the blood. And then the other side of it, the low shear, in other words, when the heart's relaxed and it's actually feeding itself during diastole with the coronary arteries, then that has to do with the stickiness. So how thin the blood is high shear, and then the stickiness of it is the low shear portion. So you almost have to look at it in two modalities. And when you do that, that explains why, we address different things like hydration. I just completed a clinical trial, a very involved RCT that showed, the effects of hydration in prevention of hypertension. And that was basically, again, because I was making the blood thinner, if you will, or positively influencing the high shear or the blood viscosity during systole. The counter side of that is when people do have blood clots, i.e., that's usually in the heart. Well, that's usually the stickiness of the blood. And you mentioned that again with the belly fat effect, with a number of the different, the hyperglycemias, insulin resistance, etc. Back to these particle sizes. See, that's what's exciting. See, now we look at, pattern A, pattern B, as far as, the low density lipoproteins. Well, guess what? The small, dense ones, those act, when you have high blood viscosity, I tell my patients, I said, it's like getting sandblasted by really tight, tiny little BBs. Whereas the pattern E, small, dense, those are bad. Pattern A are big and fluffy. So I said, would you rather get hit by a BB or would you rather get hit by, cotton ball? And everybody said, well, cotton ball. Well, that's the same thing that's going on. So you look at American Heart Association, they'll tell you right there on their website, there's just as many people succumb to an acute MI with a cholesterol below 150. It's just much more complicated, and you're certainly on top of it, but I really think the blood viscosity sort of adds sort of like Paul Harvey now for the rest of the story. So when I see patients, I do a VAP, the vertical, assessment profile, and, Berkeley now got acquired by Quest, so my patients can get that done. And, then that's what the total tools I look at to determine what I need to do. Is it a particle size? And then back it up. Is it more of a insulin resistant type of thing? So
sure. And I would love for you to expand on that. We mentioned particle size, but I just want to make sure everyone knows that we're talking about, Ralph. So when you're talking about these particles, let's just expand on that. What type of particles? And cholesterol is not all the same. Can you go through that? And if you have any analogies, kind of like the alpha-2 macroglobulin and the fire truck using particles, I'd love to hear that as well.
First of all, I'm talking about low-density lipoproteins. And before, your conventional doctor, if I may, would say, the good cholesterol was the HD, the high-density lipoprotein, which was, again, sort of taking the garbage out. It's, and you mentioned it in the book, too. Again, most of your cholesterol, 80% of it or so, is determined by what your liver function's doing. There's just a small dietary input with that. So anyway, you have HDL, the good cholesterol, and then the LDL proverbially was the bad cholesterol. Well, I always, sort of like I tell my patients, well, it depends which pattern you have as to which one is, how bad is it bad, So LDL is low density lipoprotein, and then when they're very small and dense packages of fats, then those are called pattern B. And I think they use they do like electrophoresis in the lab to sort of see the size of the particles. So when those small, dense ones, every time the heart beats, they're slamming into the inside of the blood arteries. And those can actually cause what we call sterile inflammatory or excoriations. They have a high residual or residency time on the endothelium, and that has been noted to decrease nitric oxide function. And not to get too wonky, but that's what allows your blood vessels to, contract and dilate. And when they get really tight and resistant, then hypertension goes up, and then, you just start down that road of atherogenesis. So back to those low density, these so-called bad cholesterols, if you have pattern A, those are big and fluffy. So again, when those get slammed up against the artery, they're kissing them, really. So it doesn't cause that damage that we see specifically in the LDL, pattern B. So you really need, size matters, especially with cholesterol. So, you need to know how big those particle sizes are. And actually, just to give you to drive this home, if everything was identical in a patient, lab works were identical, everything was identical, except they had pattern B, bad, as a pattern A, that would increase their risk of a heart attack, stroke, 4-fold. So that's why that's why the particle size, the lipoparticle size does matter. And again, I was really excited because you drove that all home with, adipose tissues being its own endocrine glands out of control. It's just one fire after another, and you really have to break that cycle.
Yeah, well said, Ralph. So one analogy that I've been using, if we think of like LDL of 100, well, and we think of coins, if we want to make 100 cents, we can have 4 quarters, and that's 100 cents. That equals $1. Another way that we can make $1 or 100 is 100 pennies. Now, if you were to put 4 quarters on the floor next to 100 pennies, well, you can see which one would have more surface area. And to get back to what you're talking about, shear and stress and just, overburdening the cardiovascular system, obviously if you have these little BBs, which would be the 100, the small dense LDLs, the pattern B that we're referring to, that's going to be the BBs. When you talk about the cotton balls, that would be like your quarters. Both equal 100, like an LDL of 100 or an LDL of 120, but it's really the particle size and particle number that people need to be looking at. And it's so funny. I have family members that send me their lab work from just an HMO or their general family doc or internal medicine doc. And 9 times out of 10, Ralph, there's no expanded lipid test on there. It's just a standard cholesterol test. And they say, what do you think, Mike? I said, it's like, it doesn't really mean much. I mean, really, like you said, you go on the American Heart Association website and you can see more than 50% of individuals that have a fatal myocardial infarction have so-called normal cholesterol. So I don't know how long it's going to take to change the paradigm, but it's really interesting.
It is. And, I do lots of consults by telephone and et cetera. And we won't even have a phone call until I see their, I prefer Berkeley, and then their blood viscosity tests, those, and then thyroid and, a lot of other vitamin D levels, 25 hydroxy, et cetera, CRP. Yeah, and it's just, I don't want to waste my patient's time. I just say, this is a bare minimal. Then we can engage in an effective evaluation and a corrective action plan for that particular patient. And I look at everything, obviously, with lifestyle and environmental attributes, etc.
Sure. So you mentioned the blood viscosity test. That's something that you've helped to bring to be commercially available. Let's talk about that. What is it? How can individuals get access to it?
Oh, absolutely. I used this back in 2001, and just to show you, I'll just tell you a quick example. I was using a prototype one on an Indian reservation, and what I found out was that was the most. When I saw an escalation in blood viscosity, that was the single best predictor for me that patient was insulin resistant. Of course, I worked on an Indian reservation, and so greater than 50% of my patients fell into that category. But I just want to mention that because it really does drive in what you're talking about the insulin sensitivity, and then, it really does, and the pi 1, and then, the small particles, the pattern B, and then that really does increase the thickness of the blood. So I helped get that into a commercial lab. It's FDA approved. Again, I've been talking with, a number of people, leaders in the American Heart Association, and they actually are running articles mentioning blood viscosity. So anybody listening out there, feel free to go to www.bloodflowonline.com. And what we've done is archived all the research and dealing with whole blood viscosity. So, that's certainly available for the public to review.
That's fantastic. Now, do you have any proprietary testing modalities, or I know you worked with, hormone expert Jonathan Wright on this. Explore that a little bit, and, how can we access this test, this blood viscosity test?
Absolutely. Yeah. Among a lot of things, having a great honor to work at Tahoma and being, have Dr. Jonathan Wright as my preceptor. I also was working in the laboratory, MeridianValleyLab.com, or Meridian Valley, because I was there in Seattle because of the innovative nature of that lab. And Dr. Wright, quite honestly, was very enthusiastic about blood viscosity. They were the first laboratory to make this test commercially available. And so if you go to that website, there's a number of PowerPoint and a number of presentations for that. Blood viscosity really is where the rubber hits the road. I'll tell my patients, we'll work with a lot of different things, but I need to know, are you in imminent threat of a heart attack, stroke, deep vein blood clot, pulmonary emboli? And I have ranges, just like we have, different, ranges for blood pressure. I have ranges where I know, we call them critical values. That's where the lab calls you and say, hey, this is a life-threatening value for it. And so it allows me to triage, if you will, my patient and is this someone I can sort of, put on a fairly, mellow preventative cardiac rehab program, or is this like a 911? This guy, this patient needs immediate attention to get him out of the danger zone, if you will. So that's, invaluable. And I can't tell you how many patients, whose lives were probably saved by it. I see it time and time again.
Oh, that's amazing. Now, Ralph, is this a blood test or is this some sort of in-office procedure?
Oh, I'm sorry. Yeah, no, it's a blood test. Like I said, the equipment is FDA approved. So what you would do is have your physician order that for you. They would send you out a kit, and in there would be a couple of tubes, and then you'd have either your doctor's office or a phlebotomist, draw the blood, and then ship it back to the lab. And then we would, they have consulting physicians that review labs. So I trained most of them so they could actually interpret those results with the ordering physician. And again, it's like the first go-to test when I get a consult because, I need to assess the sense of urgency for this patient's care.
Oh, absolutely. What are some things we can do? Obviously, we talked about belly fat and insulin sensitivity and all that. But one thing you mentioned in a presentation that I saw you give a couple of years ago was donating blood and exercise. Do you want to expand on those two things?
Oh, absolutely. And I have to mention I completed an article for Perfusion, which is a cardiovascular journal. I know what's a family medicine guy doing in there, right? But it was because I had reviewed all the literature, and what I found was that patients who donated blood frequently, and I just did it about 3 days ago, decreased their overall incidence of heart attacks and strokes 88 to 90%. So put that in perspective, if you completely embrace your pharmaceuticals research, they're saying maybe 18 to 22% with statin drugs. There is some validity in that because statin drugs will decrease blood viscosity. But I'm just showing you, here's almost a fourfold therapeutic benefit by just donating. So it's good for you and it's good for humanity. I mean, it's really hard to go wrong. And specifically that, you want to go and do what I call, and this, I'm assuming you're a healthy person. We certainly want to, our blood supplies here in the United States is excellent compared to many other countries. But short story is you want to donate 2 units, and we call that a 2-unit donation, and you can do that every 4 months. And so really, donate 3 times a year. You're going to be doing a tremendous service for the blood bank, and you're also going to be helping yourself in the prevention of, like you said earlier, one of the largest causes of death in the industrial nation.
That's amazing. I'm not a fan of venipuncture and needles, but I would like to reduce my risk by 88%. So I'm going to do that. I'll let you guys know how that goes. So I hope everyone, and it's free, right, Ralph? I mean, donating blood is. You're
in Seattle, correct? Excellent service there with, it escapes me, but I think it's the Seattle Blood Bank, but don't quote me, but I continued donating when I was there, and so you have a tremendous resource. You just schedule it, and you're able to do that. Yep.
All right. Well, this has been amazing. I really appreciate all the work you're doing, and a true pioneer in both, enzyme therapy and also blood viscosity. So, Ralph, as we part here, I would like to, in the show notes, we'll have your bloodflowonline.com and meridianvalleylab.com, but any other websites, your personal website, or links to your books, you want to talk about that now?
Well, I think healthonvector.com, so health and then O-N vector, VECTOR.com. Yeah, I don't have my own website per se, but at least you'll have access with bloodflowonline.com with my research that I've done in blood viscosity. And then hydration was the other one, if I can just sort of, I did a study right there in Seattle with firefighters. I actually used essential water, which is a reduced alkalinized water, And very small pilot study, but it showed that we could rehydrate and decrease blood viscosity tremendously. So there's another tool. Donate blood and drink water.
I love it. All right. Well, thank you so much for joining us again, Ralph. This was awesome. We'll make this available, and really appreciate your time and expertise. And thank you for coming on the show.
Well, thank you, Mike. And again, you've really helped me connect the dots in my area back to, the other dynamics in the body from, the endocrine, particularly with the adipose tissues. So my hat's off to you.